Let's get on with the program. We have a tight program. Our first session is called Rheumatoid Arthritis, Revolutionary Advances in Therapy. We're going to begin with a great speaker from the University of Colorado, Dr. Kevin Deane. Kevin's going to talk about preclinical RA to treat or not to treat. Dr. Deane.
Thank you. Thanks so much for the invitation. You know, I have to confess, I thought this was in Houston because I didn't really look at the program carefully. Why is that a problem? Well, my niece lives here and found out last night that I was actually in Dallas, and so I have to take care of that. Okay, anyway, so it's good to be here. I'm going to pack a lot of information here, a lot of slides. Hopefully this will go well and you will leave feeling informed. I have some disclosures, a couple of evidence-based reviews which are also available to you through the educational materials. I encourage you to take a look at these. My primary goals today are to generate enthusiasm with the next few years. We're going to have an intent to prevent in rheumatoid arthritis and maybe other rheumatic diseases as well. I'm going to really focus today on updates and research and focus mostly on clinical care. I'm going to give you a lot of slides, some of which are for your information to look at later. I won't spend a lot of time on that in the interest of time today. So I'll start with the case study. A 35-year-old female, 1 year of progressively worsening joint pain, stiffness, and swelling. She's gone to primary care several times in the course of that year. Recently, the primary care noticed some swelling in her MCPs and sent some labs. The CCP is elevated at 68 units. Rheumatoid factor as well is elevated. And she's referred to rheumatology for further evaluation. Rheumatology finds multiple tender and swollen joints consistent with active synovitis. With those labs, even though plain x-rays are normal and no other imaging was thought to be necessary at that time, she was diagnosed with rheumatoid arthritis. Methotrexate started about 15 months after the onset of symptoms. I think this case will probably sound very familiar to all of you. It's actually a real case. It's very important to know how to help this person, really improve access. 15 months is too long, right? It's outside of our guidelines. We'd love to catch this person even earlier. Of course, improve treatments. As we know, treating that person will have a lot of different layers to that and trying to get them back into feeling good. Early diagnosis and treatment is currently the best way that we have to improve long-term outcomes in rheumatoid arthritis, so it's incredibly important how to do that. But the rest of this talk is going to be focusing on RA is worth preventing, because unless you think it's worth preventing, nothing will really go forward in this area. It's a forever disease. Once somebody gets their first swollen joints, for the most people, that is forever. They'll be on medications forever. 50% don't respond well. This is controversial. I can fight with you later at the cocktail reception on that. But how do you mean well? Well, most people, if you get rheumatoid arthritis, don't feel as good as they did before they had rheumatoid arthritis, and I think that's an important point. It's very costly in terms of dollars and well-being and person years. Individual preferences, if you ask anybody with rheumatoid arthritis, which we have done, you'll invariably find they wish they hadn't gotten rheumatoid arthritis, and if they have it, they don't want their loved ones or others to get it as well. So here's case study number 2 to set some points into place here. 35-year-old female who has joint pain. Her primary care found tenderness on examination, but no swelling. Did the same labs as the other lady had. CCP, rheumatoid factor, for virtue of this presentation, are the same. Primary care diagnosed this as rheumatoid arthritis based on the tenderness in the lab test, which I think you all see, then referred to rheumatology. Rheumatologist finds symptoms of joint pain, but really no careful examination finds any swelling. So no swelling on examination, but imaging was done. Ultrasound first that was done in the clinic didn't see any synovitis. And then a little while later, an MRI was done, which showed synovitis in one MCP and one wrist. And then this comes to the first set of questions here. What would you do? And I don't want to spend a huge amount of time on this, but get these thoughts in your head here. Educate about RA, recommend modification of possible risk factors. Treat with either hydroxychloroquine, methotrexate, with some other agent you'd like. Wait and watch until she develops joint swelling that you can appreciate on physical examination. So keep those questions in mind. Oh, here it is. It's formally in the poll. And you all can tell me what's the next steps from my end on this. Okay. I'll move to the next. Is this right? I can move to the next case study? Okay. So case study number 3. You'll see this as a subtle twist on that earlier one. 35-year-old woman feels fine, but her mom has rheumatoid arthritis, so she asks her healthcare providers, will I get rheumatoid arthritis? And if yes, what can we do to prevent it? Rheumatologist evaluation, we skipped the primary care at this finding. Examination is normal, no joints are tender or swollen, but some lab tests are done, and she has exactly the same profile labs as the other people did. CCP elevated, rheumatoid factor elevated, but ultrasound and MRI was done, which is normal. Now, what would you do in this case? Poll. Excellent. I see the top answer there is gaining some favor. We'll talk more about these details on the prior case and this case as well as I move along here. Okay. This is going to be a complicated slide. I spend the most time of any slides that I have today, but I want to really make sure that we understand this. Though we now think the natural history of rheumatoid arthritis develops as such, where you start with genetic and environmental risk factors, and there's multiple ones of these. I won't spend a lot of time on that today. That then triggers probably local and then systemic autoimmunity. When I say local, we really think there's emerging data. This is probably happening outside of the joints, probably to mucosal surface at this very early part, where we can find things like ACPA or CCP, rheumatoid factor generated at mucosal surfaces that then become blood-based that you can detect with our standard lab tests. Then this may develop into a next stage, which is subclinical arthritis, which is a controversial term and concept, but this would be joint inflammation that you may not see even as an expert rheumatologist on your physical exam of the joints, but might be seen on imaging, and the patient may feel something that, again, we couldn't see. This can then progress to unclassified arthritis, which is defined as, yes, that looks like inflammatory arthritis, but not meeting formal criteria for rheumatoid arthritis. Then it can progress to classifiable rheumatoid arthritis, and importantly, persistent rheumatoid arthritis, because I think we all know that rheumatoid arthritis has some features that can be palindromic in some individuals, and so persistent arthritis is the type of arthritis that comes and stays. This is sort of a pictorial representation of the differences of undifferentiated versus meeting 2010 or 1987 criteria. And the concept I want to get across here today is there's probably two parts to this, that there's a non-articular phase of rheumatoid arthritis where really the joints are not involved. Autoimmunity that's related to RA is present, perhaps triggered at a mucosal site, but not in the joints yet. And then part of that's now articular rheumatoid arthritis, at which point you can have the subclinical or unclassified or classifiable rheumatoid arthritis. The point at which we'd see them in clinic and make a clinical diagnosis, regardless of whether they met criteria or not, but we'd say, this looks like RA, I'm going to treat it, I'm going to term clinical rheumatoid arthritis. Importantly, throughout all this, in addition to what we can see on joint examination as rheumatologists, there may be these periods of time where you don't have any symptoms. This may be truly the non-articular phase, or people can start to feel symptoms that, again, we can't necessarily see as related to inflammatory disease. There's a formal term that's being applied mostly in Europe at this point called clinically suspect arthralgia, or CSA. It's a very important concept that I won't spend a lot of time with. I encourage you to learn about that a little bit later. And of course, there's non-articular symptoms that are in this early phase, even before the arthritis, as well as persist throughout the arthritic phase. These are symptoms such as fatigue, malaise, and in some individuals, they can have mucosal-based symptoms. The classic is rheumatoid arthritis, lung disease, but there can be others. Importantly, throughout this whole time, there's likely ongoing different environmental and genetic factors that are driving this whole process. We now think probably the same genes that trigger your autoimmunity are not the same things that get you to transition to disease. We all know now that, are growing our knowledge that different genes affect how well we respond to different therapies in our course of RA. The part I'm going to talk mostly about next slides is pre-RA, which I'm going to define here, and this is somewhat controversial, but this is the period of RA where you have detectable autoimmunity. You may have subclinical arthritis, but you don't have clinical arthritis yet. And just a little bit more drill into that biology of rheumatoid arthritis. This is a study our group did a few years ago, looking at around 200 cases from the military who got rheumatoid arthritis. We could go back in time and look at serum samples from before they got rheumatoid arthritis for RA-related biomarkers, as well as well-matched controls. The blue line here is a level of ACPA that's akin to the anti-CCP3 test that you may use clinically. So what we saw was 17 years prior to diagnosis, in the people who wanted to get rheumatoid arthritis, the anti-CCP3 test was elevated compared to controls. Just a little bit. It held steady for a few years, and then it took off 3 to 5 years before diagnosis. And then the red line that's going up and down, that's the time of diagnosis. Interestingly, that gray line that goes across the middle, that's the point at which that test would be called positive in your lab. So test was elevated compared to controls for a few years, then took off. This understanding of this biology, that there's something triggering RA-related autoimmunity years prior, it holds steady for a while and then expands, is fascinating, and that's sort of the biology of what's happening. Okay, back to this model here, and I'm going to put in our cases. Case 1, I think that's very obvious to us where they fit. Case 2 would fit here. Remember, she had aches and pains, nothing swollen, but imaging showed some synovitis. Then our case 3 is going to be back here. Just keep these in mind as I move ahead. So we've learned all about that whole model, and I won't spend very much time on this at all, through a couple of well-developed studies. I'm going to talk about the first one. It's the Acmel Odom people, also formerly known by the Spanish name of PIMA. This was a 20-year study that was published in 1988 that basically set this model for us. The biomarker they used was rheumatoid factor, but it basically showed go from asymptomatic to rheumatoid factor to symptoms and to rheumatoid arthritis. Fascinating study, I think very powerful study. The problem was rheumatoid factor, none of us liked that test because it's not very specific. What the next big case breaker here was the Swedish biobank study. I think most of us remember this. This was Solbert, Rantaba, Dahlquist, published in A&R in 2003. This was the anti-CCP test in the Swedish biobank that showed that this antibody comes up years before disease. This was a game changer because CCP is so specific for rheumatoid arthritis, we really realized, hey, we have something that we can predict future rheumatoid arthritis. Some more studies just for your reference. This model of RA development and biomarkers, including the CCP that show up, has led us to be able to predict future disease. And think of prediction as a diagnosis of a high-risk state for future clinical RA. It incorporates diagnostic accuracy, but again, the outcome is future disease. It's a critical part of designing prevention trials. It's a critical part of communicating with people. And it's a two-part. Are you going to get rheumatoid arthritis, and when? There are some general concepts, and I'll leave this slide mostly for your reference. Old studies that were case control show that these tests were highly specific and highly predictive for rheumatoid arthritis, but they were case control, which can overestimate risk. But now we have a growing number of prospective studies where if you're ACPA or rheumatoid factor positive or both, there's usually positive predictive values of about 20 to 60% or 20 to 80% of getting RA within the next 2 to 6 years. I'll talk about this a little bit more, but keep those numbers in mind. Think of 30% as in that range. Now this is taking us now to take the same model of disease, being able to put our cases on here and understand what's the risk of case 2 and 3 for moving through this pathway. This is mostly for your reference, but this has been more formally evaluated by a Dutch study where you can take a scoring system heavily weighted by antibodies, get a score for an individual, and you can put them on one of these lines. That red line at the bottom, heavily driven by the presence of ACPA or rheumatoid factor, but if you can eyeball it, if you have multiple factors including autoantibodies, around 50% of those people get rheumatoid arthritis by 24 months, but less or more depending on how you look at that, so 30% is a nice rule. So take-home prediction is if you're anti-CCP positive, there's about a 20 to 30% overall risk for developing articular clinical rheumatoid arthritis within the next 3 to 5 years. Probably goes up if you follow these people longer. Those studies have not been done in that length yet. Depending on the study, though, you can probably get a higher or even lower kind of prediction. Keep that number in mind. So fortunately, this natural history of RA and this ability to predict future rheumatoid arthritis has led to prevention. I'm going to spend the next few minutes talking about this before we get into some future thoughts. But importantly, in rheumatoid arthritis, you have to think about what type of prevention are we talking of. There's lots of historical understanding of types of prevention, primary, secondary, or tertiary. Those are actually very hard to apply when your understanding of disease and when disease starts changing. So operationally, in prevention studies of rheumatoid arthritis, the goal has been to stop or delay the first swollen joint on examination classifiable rheumatoid arthritis. Importantly, most of these prevention studies I'm going to talk about have been implemented in people who presented to a rheumatologist with pain but did not have inflammation on joint examination. They may or may not have had imaging findings, which I'll tell you about. Very complicated slides in the next few ones. These are mostly for your reference. I'll talk about a few high points. A study published in 2010 from the Netherlands was dexamethasone in individuals who were either rheumatoid or ACPA positive, also had a genetic factor that shared epitope, and they had joint aches and pains. 2 doses of dexamethasone, 100 milligrams, about 6 weeks apart. There was no difference in progression to inflammatory arthritis, slight decrease in antibodies in the treated folks. So it didn't work to prevent rheumatoid arthritis. But look over here. Overall, of that group, only 21% developed rheumatoid arthritis at 26 months of follow-up. So this is that 20 to 30% range. You might have expected higher, but that's what they got out of this. Next study had a bigger splash, the Prairie study. This was also done primarily in the Netherlands. They took individuals who were rheumatoid factor and ACPA positive with aches and pains, slightly elevated CRP, gave them a single dose of rituximab versus placebo. No difference in progression of rheumatoid arthritis, but the rituximab group did have a delay of the onset of their inflammatory arthritis by about 12 months. So delay, but not prevention. A last study here, STAP RA, which was using atorvastatin in the similarly high-risk group of rheumatoid factor and ACPA or high ACPA and aches and pains. Atorvastatin kind of based on some epidemiologic evidence that people on statins have less RA overall than people not on statins. They took a shot at this. Absolutely no difference in rheumatoid arthritis here. They had a lower rate of transition to rheumatoid arthritis, 24%. Admittedly, that was a little bit of a harder follow-up. So these agents haven't really worked. Now I'm going to spend a few minutes on this trial here. Treat Earlier, published last year. This was a slightly different twist. They took individuals with aches and pains who had MRI evidence of inflammation in their joints. They gave them either methylpred 1 dose plus methotrexate up to 25 milligrams per year versus placebo. There was no difference in progression to persistent RA over the 2-year period of the study. They treated them for a year and followed them for a year after that. But there were some decreased measures of disease activity and MRI inflammation. And again, I think you should have all these slides to look at, and I won't drill through some of the numbers in the interest of time. But there's some interesting findings if you drill into this study. The blue lines up there are the people who are ACPA negative or CCP negative. The red lines are people who are CCP positive. The lower line, which is pinkish colored, those are people on methotrexate. And while they were on methotrexate, they actually had slower progression to rheumatoid arthritis. That they lost that effect after they stopped the drug. But it's fascinating to think, and they didn't find this to be statistically significant, but is there an early effect of methotrexate actually at blunting this process? What they also found in this study was function and MRI inflammation improved in the methotrexate arm. So on the left-hand side, there's physical functioning measured by the HAC. People on methotrexate actually felt better on drug that persisted once they were off drug. On the right-hand side, these are MRI-based inflammation, suggesting methotrexate modulated the disease to a less severe form of disease if you took it, even if you still developed inflammatory arthritis. Now, this is a very complicated slide, but focus on the red letters. This is the STOP RA study, which I have been the PI on, which we basically took hydroxychloroquine versus placebo in individuals with high CCP. Study design was this, found people who were CCP positive, didn't care about symptoms at all. We certainly assessed those, but that wasn't an inclusion factor. Gave them hydroxychloroquine for a year versus placebo, and stopped and followed them for 2 years off study drug. And I see some members of the audience who have participated in the study, and thank you for that. I won't spend too much time, but they were very well matched groups. And here's the heartbreaker. These two curves are the individuals on Plaquenil, the blue line, and on placebo, the red line. If you were trying to draw curves that overlaid each other, you'd probably have a harder time than our actual study proved this. So absolutely no delay in development of rheumatoid arthritis, which again was heartbreaker. We thought this would be a great way to approach this disease. Didn't work. So it's disappointing. We're pending analysis to see if people actually felt better on hydroxychloroquine, even though they still progressed to disease, or if they had modified disease activity similar to that Treat RA study, so stay tuned. There's a couple of ongoing prevention trials. There's some early data out of this bottom one called ARIA, which is out of Germany, where they were given abatacept for 6 months in individuals that were ACPA positive plus had MRI findings. They are encouraging initial results. I think we have to wait for the full study, but they may actually blunt disease. In the interest of time now, I'm going to go very quickly through the next few slides to get to some few key points. But know that other studies are being studied. SMILE is in lupus, taking individuals with incomplete lupus, seeing if they can block that. There's prevention trials in psoriatic arthritis. So exciting fronts in a lot of different diseases. So there's a key point. Steroids alone, rituximab, atorvastatin, methotrexate, did not stop progression to clinical RA. Rituximab times 1 dose may delay RA, but that's probably not something we're going to be doing in clinical care anytime soon. Methotrexate may improve symptoms and the severity of RA. We're waiting to see how hydroxychloroquine affects in that space. Preliminary abatacept may delay. It might reduce symptoms, but we have to see. Currently, we've focused on prevention, but this treat earlier study has really understood maybe we're actually treating something now, not just thinking about prevention of RA in the future, but for making people feel better now or modulating disease. This may be a new way to get at this. So a couple key questions I'm going to whip through here as I see my moderators are on the stage already. We really do have to understand what RA is, and maybe we'll start defining it differently. We've thought about clinical RA as a swollen joint on examination or classifiable disease. We may have to start thinking differently about that. We have to know who needs what therapy, why are standard DNRs not working? We all thought they would work better in all these trials, and they really haven't. And of course, what's driving the development of disease will underpin studies in the future. This is that picture I showed you before. Understanding each of these stages and what's happening biologically at each of these points is important. And that green explosion in the middle there is why do some people develop autoimmunity and then hold steady in a benign autoimmune state for years? If we could figure that out, maybe we could give more people those interventions to help modulate their disease. I have a fifth point that I'm going to spend the last minute on here is what do I do now as a rheumatologist for someone who has either pain or no pain or abnormal autoantibodies? This is what I do. These are not guidelines. This is being hotly studied now, so hopefully we'll have some better information for you all going forward. I carefully examine to identify synovitis. If they have synovitis, I would call this person RA. I'll tell you about imaging in a second. Educate on RA and symptoms and known prediction, which I use this number of 30% risk in the next 3 to 5 years. I promote research if possible. I recommend lifestyle changes that may impact immune health. These are not studied, this is a caveat, they're not studied to prevent rheumatoid arthritis, but it can involve smoking cessation, healthy weight, exercise, diet, Mediterranean diet, has some potential general health benefits, and may actually blunt disease. Periodontal health is a big question I get asked about. We actually don't know if brushing your teeth prevents rheumatoid arthritis, but it's good for your teeth, so it's reasonable to advise. Some people have argued, could it be worse if you have an autoimmune state and then you start flossing at that point? Could that actually trigger autoimmunity? It's an area we have to think about, but I think in general, good dental health is good. I like annual in-person clinical follow-up because in my experience in pre-RA, would you believe the onset of rheumatoid arthritis in most people is pretty subtle and not crippling at the onset? And we actually find people who know they're CCP positive come in with swollen joints and say, you know, I actually didn't feel that bad. I wasn't sure if I was supposed to call you or not. And really seeing these people and continuing education is critically important. All right, this is this model again. I won't spend much more time on this, but this is hopefully now going to move us to the point we're going to be able to take these two cases and understand what to do with them. A couple seconds here on imaging. I feel that the role of imaging is not clear. There's others who are more expert than I. Phil Conahan's going to speak a little bit later. He's certainly an expert in this area. It's not clear what we should be doing routinely with this at this point. And certainly we have different modalities. We have ultrasound, we have MRI. Our current gold standard is really clinical diagnosis based on your examination. I don't even know where synovial biopsy may fit into this. Irish are doing some interesting studies looking at biopsies in this early period. We'll have to see. Consider, though, imaging is expensive, very hard to interpret in some people, especially in this early disease. But if you decide to treat, use imaging or other things to treat, please counsel that whatever you do may not prevent developing rheumatoid arthritis, but it might make them feel better, may modulate disease. I'll leave this up to you, no guidelines. A couple of questions here. What is critical for rheumatology to address? In interest of time, I'm going to leave this mostly for you to read, but I think we have to all know in the field, what do we call this? How do we define these things? How do we find effective therapies and know that there's going to be more studies going on in the future? We have to find out ways to find at-risk people. I will just tell you right now, I advocate for really good biomarkers tested broadly in the population, like we all do in internal medicine for cholesterol screening, diabetes screening. They have to be very careful with that, make sure our tests are really good. But I think I would love to move us into that period. If we sit around and wait for people to have aches and pains and then check CCP, I think that's really going to find RA at a too late of a state. Stay tuned on that. I'm happy to fight you over that at cocktails tonight. I would say one thing, if we felt more comfortable, if of all the people who are ACPA positive, we know 30% on average progress to RA. If we could understand that better, I think that would make us all feel more comfortable, and people are really looking into that in the way in the future. Some images to balance into your mind. We really do want to balance over-treatment of the wrong people, under-treatment of the right people. And also trying to understand how each of us get there, because I think you've probably all seen each one of these cases of rheumatoid arthritis. Let me tell you, each of these people are probably coming to their RA in a different way. Understanding that's going to be important. Oop, this is a bad slide generator. That's me. Summary, we can identify people who get before they get clinical RA. At-risk individuals may come to your clinic. 30% is a nice rule for who's going to move on to clinical RA. Trials to date have not found effective prevention, but emerging possibility to modify symptoms or modulate future disease. We need more studies. We can counsel and make shared decisions whether you're going to intervene or not. And please stay tuned for more research in this area. And really, I think the future of rheumatology is, I'm tired of waiting for people to get sick and finally showing up in our clinic. If we can really move disease into prevention, I think we're going to do better. This is mostly a review. I've had subfunding, especially for the Stop RA study from the NIH, so I thank them for that. Again, I thank everybody in the room who has participated in the Stop RA study. And with that, I'll stop. I'm over time. Sorry.
All right, thank you. I want to remind the audience, both at home and here, that if you have questions for the speakers, it's in the player, it's under polling, and there's a green tab, and you can ask the questions. We'll be doing that during our half-hour panel discussion. But two quick questions, Kevin, before we go on to our next talk. One is nosology count. There's undifferentiated arthritis. There's at-risk. You use preclinical RA. There's clinically suspect arthralgia. Are they all the same?
No, and depending on who you talk to, the exact same term may be defined differently. And so it's a huge problem. So I won't have a good answer for you. They're not the same. I think the field needs to come up with well-defined terms. Okay. And they're working on it, but it's slow progress.
Dr. Adwala in the virtual audience asks, is there another biomarker for early RA?
So there are growing numbers of biomarkers that we're trying to interpret. As a general concept, it's likely not going to be a single biomarker, but a panel of biomarkers that's going to be helpful. So it's going to be something like an ACPA test plus something else that's going to allow us to understand better where somebody is at in that evolution of rheumatoid arthritis, and more specifically. So you might have seen in research studies we can actually break apart a CCP test into its individual components, but that's not clinically available. I would say the future is looking at multiple biomarkers to kind of give a score that will give us a better idea of where people are at. So I'd say great concept and great question. Stay tuned for better data and more actionable testing.
Excellent. All right. Thank you, Dr. Deane.
All right. Thank you.